Welcome to Understanding Acquired Brain Injury for Families with Dr. Tracey Meyers.
Hello, my name is Tracey Meyers. I'm a licensed clinical psychologist, and I've been working in the field of neuropsychology and brain injury for the past 25 years. And I'll be talking today about families and the impact of acquired brain injuries on families ongoing. This is a topic that's really important to me, as I've been working with many families over the course of my career and have really seen lots of challenges and lots of beautiful outcomes when families are supporting their brain injury survivors. So even the title, it's not just the patient, is this idea when we're treating someone that's had a brain injury, we are treating the whole family system. I'd like to give a shout out to the Brain Injury Association of America and the Academy of Certified Brain Injury Specialists, who do a wonderful job providing advocacy and training for people to understand the needs of brain injury survivors. And some of the slides, as they're marked, are from their support. So I'll be talking about acquired brain injury, including behavioral and emotional changes that happen, how families respond to brain injury. We'll talk about models of adjustment, because there are different ways to think about how families are adjusting over the course of someone's brain injury. Specific family member reactions, spouses, parents, children, interventions for the family system, and a case example to kind of bring that all together. So just a quick overview of acquired brain injury. An injury to the brain that is not hereditary, congenital, or degenerative, or induced by a birth trauma. So it occurs after a normal brain development, results in changes in the neuronal activity, which can affect the physical integrity, the metabolic activity, or the functional ability of the nerve cells in the brain after an injury. And it's really an umbrella diagnosis that helps us to understand different kinds of insults to the brain. It can include external physical forces that are applied to the head, as well as internal insults to the brain. So TBI is a specific form of acquired brain injury, an alteration in brain functions as a result of an external force. The head is struck by an object, or an object strikes the head, and this can result in either an open or closed injury. So we'll be talking about traumatic brain injuries and acquired brain injuries throughout this presentation today. So family response to acquired brain injury. So if we think about families as a system, right? And in anyone's family system, whether you've had a survivor with an injury or not, there are roles and relationships that stay in a relative balance, right? So everyone has their specific role, and how everyone is interacting, that really establishes our family norms, right? But the balance is broken as soon as a person sustains a brain injury. The norms, the relationships, and the roles all get shifted. So a traumatic brain injury or acquired brain injury, I'll be using those interchangeably, can cause catastrophic losses and can cause a lot of changes that are very difficult for family members. So not only does the individual have the brain injury, but the system itself is in effect injured. So there are changes to both the individual and the family system. So possible family issues after acquired brain injury. And there's many listed here, but I want to just go through most of these so we can see the scope of how significant an injury to an individual can actually have on the whole system. So this is for the family. Families can feel anxious or confused about the brain injury, what's actually happening. We call that sequelae, what's developed as a result of the brain injury. They can have mixed feelings about the person, even though they love them. They could be angry, disgusted, frustrated. They can feel uncomfortable because they feel like they're living with a stranger now. This person they used to know is completely different, right? Someone that you married is now not that same person. The injury-related problems don't stop when the person comes home. They actually can increase. Families can be very disappointed at the outcomes. They may be so relieved that their family member survives, and then they come home and realize, wow, this person has so many problems. The failure of the system to recognize the whole family is impacted, right? So often the treatment's focused on the individual. Families can feel guilty, feelings of guilt, or maybe feeling guilty about having negative feelings toward their loved one. It's a loss, right? Loss of relationships, because that person may not be the same person they were before, which can cause family members to feel isolated and alone. Neglecting oneself. We're going to be talking in another webinar about self-care for the caregiver. So this neglect, because all of the focus is on the loved one who had the brain injury. Feeling stressed and overwhelmed, having difficulty remaining patient, which of course makes sense when there's ongoing care needs. And that can affect problem solving. And often when we're feeling under stress, we tend to blame other people. So this can happen in a family system, right? Family members can turn on one another because there's so much stress. Focusing on the negative, and this happens often when there's so much stress in the system, we tend to focus on the negative and get really caught up in worrying. Feeling frustrated because there's competing or contradictory evidence that one doctor might say this, one therapist might say that, and that can be very frustrating. You can lose track of documents, when you're trying to apply for Medicaid, for example, or do a conservator paperwork. It can be very overwhelming. It can be hard to ask for help. A lot of times people don't want to ask or avoid direct and honest communications because it's so painful. And then feeling protective and not wanting to talk to other people about what's happening in the family system. We see that with trauma, any kind of trauma, but often with brain injury, right? And then not even wanting to ask questions because, again, it can feel like you're either being a burden or it's too overwhelming. So you get a sense here of how vast these problems can be. It doesn't mean that all families have all of these, but I've worked with many, many families who struggle with several of these, and it can come and go, right? There can be times where things are more stable. I'm going to be talking about that in a few moments, about like the sort of the sequence of coping, but also some of these are ongoing as well. So when we think about the family and the caregiver, we're thinking about this, what we call distress, caregiver distress, and it can come from the patient or the brain injury survivor, right? So their impairments, cognitive, social, and behavioral, particularly behavioral, can impact a caregiver. That's what we're talking about, personality changes, someone who becomes potentially violent or aggressive, right? That can increase caregiver distress. And then a caregiver's own individual support, lifestyle, work, all of those things. So those, they're kind of getting squeezed in both directions, right? Impairment of the person and the caregiver's unmet supports and needs themselves. So the most potent and painful aspects that family members struggle with are usually around the behavioral and emotional changes following a brain injury. And this table here just shows how pervasive those emotional and behavioral changes can be. Now, again, everyone is different. Everyone who has a brain injury has different challenges and different strengths. So this doesn't mean that everybody has all of these, but if you look at the level of intensity, from irritability to physical aggression, from sadness to suicide, this continuum, you can see how families really will struggle, especially when family members have more extreme anger, depression, thinking issues, psychiatric symptoms, right? How all of that contributes to the level of distress for the caregiver. And when personality changes are significant, it is extremely difficult for family members to cope. So how does the family respond? And there are a couple different models I want to share. It's not like one model is better, but I think it highlights that it's a process. It's an ongoing process, and there are phases that we need to consider when working with families. So this is one phase. I'm going to show you a couple of different ones. This is called the 3-phase model, and it mirrors the recovery that a brain injury survivor has also, because just like the survivor is going through a phased recovery, so is the family. Acute, rehabilitation, and integration phases make up this 3-phase model. So in the acute phase, the focus is on survival, medical stabilization, and minimizing permanent damage. So for the family, we think about the bedside vigils, the staying at the hospital, the just life stops during the acute phase for many family members, right? It's just about, will my loved one survive, right? So it can be extremely terrifying, anxiety provoking. And the wish, of course, is that their loved one is going to survive and be able to come out of, if they're in a coma or if they're in the ICU. Once the rehabilitation phase has entered, the expectation is usually high for families and individuals, right? So it's like, we're going to get back to life. So maybe the loved one is in a rehabilitation hospital or nursing home, getting physical therapy, occupational therapy, neuropsychological testing. So the family is in a hopeful phase. And the focus is on getting back to their regular level of functioning if possible. And then finally, this integration phase, which is gradually integrating the person back into the community. And it requires acceptance because some of the deficits that were worked on in rehabilitation and hoped to be able to overcome have not, right? And so there's a sense of, okay, this is the new normal, the new equilibrium for the family. And this phase can take a long time. In fact, it can take a lifetime because the family equilibrium has shifted so much. And also people continue to improve and change over time. And sometimes, unfortunately, can get worse over time. So we see this integration phase as an ongoing phase that has different phases within it, depending on how the person is doing, right? So these three phases, acute, rehabilitation, and integration, are phases for both the individual and the family. We can also look at family responses through a grief model, right? So just like the stages of grief, which Elizabeth Kubler-Ross described in her famous model, talking about how there are predictable stages of grief when someone is experiencing a loss or a death. It's very similar with a brain injury, right? We can see with family members also the initial shock, maybe unrealistic expectations, emotional relief that the person survived. That's like that acute phase, but then unrealistic expectations for a full recovery. And then moving toward more of that acknowledgement of permanent deficits, which might take place in that community transition. And sometimes a bargaining, like, oh, if my loved one, if only they could, stop yelling so much, then I could, I could tolerate this, right? There's also mourning. We're going to talk a little bit about mourning in a moment, but grieving or mourning of the loss. And then acceptance and restructuring, finding that balance again. So like the stages of grief by Elizabeth Kubler-Ross, this grief reaction model also acknowledges that we go back and forth, that it's not always exactly one following the other, and it's a permanent working through to getting to acceptance. Sometimes people go back to denial, sometimes bargaining, sometimes mourning stays persistent, right? And maybe people don't get to acceptance and restructuring. But it's helpful when working with families to really acknowledge the grief, to give them permission to say, this is difficult and I am mourning, right? When people can acknowledge how they're feeling, we see generally better outcomes and more willingness to get support. So let's talk about mourning. And there's a particular type of mourning that often occurs when families are responding to acquired brain injuries. It's something called mobile mourning. Families experience a grieving process repeatedly. This is the mobile mourning. This is this idea that mourning occurs over and over because the brain injured person is a constant reminder of a loss. When someone passes away, of course, there is a mourning period of time, which could last a long time, but that reminder of the person is not there or as significant. But when the person is actually there, but they're no longer the same person, it raises different emotions, feelings, and challenges. So mobile mourning essentially is a moving target because the changes or the losses continue to morph over time. The injured individual and the family can't actually grieve initially for something until they realize later on, oh, this person's no longer able to work. And so now, 5 years later, we thought they could go back to work. They can't. And so we're going to mourn the part of them that was a really successful business executive, for example. Or mourning, maybe the person's never going to be able to have children. And so family members may be mourning the loss of grandchildren that may never happen, right? And some of these changes or recognitions don't happen for years after the initial brain injury. So there's a lot of uncertainty that pervades this mobile mourning process. And it can actually be really disorganizing to a family system. We talked about how families have a delicate balance of roles, relationships, and when that is disrupted and there's not a reorganization or a clear reorganization, there can be extended or permanent turmoil in a family system. We don't know if dad is actually going to be able to ever do this. We don't know how much care, Sally is going to need, and maybe we're not able to care for her, right, over time. So you can imagine how families are continuing to adjust and then get maybe destabilized. So mobile mourning can cause a lot of fluctuations in mood, from euphoria, looks like the person's getting better, to despair, resentment, rage, denial, realism, and back and forth between these different states, right? So it's very painful when we think about how mobile mourning continues across often the lifetime of the TBI survivor and their family. So there's another model I want to share with you. This is called a 6-stage model for families. And it's really, again, looking at the trajectory of recovery and how the brain injury survivor and their family shift over time. So the 6-stage model, designed by a neuropsychologist named Muriel Lezak, she talks about stage 1 as out of reach. This is in the initial 1 to 3 months. The family perceive the individual as hurt, weak, tired, inactive, and they expect full recovery, full regaining of their lifestyle. So the family typically is happy and hopeful, right? You can see some overlap with those other models. That's like very similar to the acute phase, right? We want the person to survive and they're going to get better. Stage 2 is called up in the air. So this is 3 to 9 months. So maybe they've progressed from acute care to rehabilitation, maybe into the community. Family's perception, he's not cooperating, he's not motivated, he's self-centered. So they're starting to see some of those signs and symptoms that appear after a brain injury. Full recovery, if only the person would try harder. And we see this a lot. Families are really pushing. They need more PT, they need more medication, they need this and that. And often families are feeling bewildered, anxious, and scared. So you may be seeing some of that mobile mourning and stages of grief playing out, right? Particularly once they get out of the danger acute care zone. Stage 3, down and out, this can be ongoing. So there's sort of this 6 to 9 months or 9 to 24. So let's say 1 to 2 years, but it could be indefinitely. The family is feeling like the person is irresponsible, cranky, egocentric, right? So it gets a little bit more negative, more blaming, right? You can feel that like blame toward the brain injury survivor. The family feels like, oh, if only we knew how to help him. So they may feel guilty as well. And the family starts to get discouraged and depressed, feel like they're going crazy, guilty, not doing enough, right? So this can be very painful, and the stage 2 can last, ongoing. Stage 4, no way out. This is, again, typically later on in brain injury recovery. He's different. He's difficult to be around. He's a child. We can, of course, depending on the person and the gender, we can add different role changes in there. Family expectation, no hope, but a lingering wish for things to be different. And the reaction can be despair, feeling trapped. Stage 5, profound sadness. So again, you can see sort of these stages of grief. If we were imagining that, like overlaying this model, at least 15 months or after. This is a more short-lived family perception. He's turned into a child, completely dependent. You can almost feel like a giving up here. Family expectation, none. Like it's almost like we dropped our expectation, and there's deep mourning, right? Now, of course, it doesn't always mean that the family sees the person as a child, but there's this sense of giving up the hopes and dreams. And then there's the stage 6, lost and found, which we hope will happen, 18 to 24 months. And again, the family perception language, he is and will always be a dependent child. I would not necessarily say that families see it that way, but the recognition that they may need ongoing supports. Family expectation is more supportive and person-centered, whatever the person wants. And the family really starts to shift. There's more acceptance and stepping back, more positivity. So when families get here, you see often lots and lots of joy and enjoyment of the family, time together, enjoyment of the loved one again. There's a new equilibrium that looks different than the old equilibrium, but there's some balance found again. And families do get to this, not all families, but many do. Other families get stuck in earlier stages, but it is helpful to sometimes review these models with families so that they don't feel like something's wrong with them. The guilt that many families can feel when they are angry at their loved one or frustrated or have given up, it feels like, well, I'm supposed to love and support this person. How could I feel this way? And so when we give them these models, it can just help to normalize and support family members. And that's what we're going to be talking about next. So family burdens, there are behavioral, affective, and personality changes. And those changes cause the most burden. Thinking back to that earlier slide that listed many of the changes that can happen to a person after a brain injury. So those, the research has shown, produce the most burden, caregiver burden. Cognitive changes cause intermediate levels of burden, so still some, but not as significant. And interestingly, physical changes cause the least burden. So even if the person has profound physical changes that they need, support in all of their activities of daily living, that's still not as stressful as the behavior, mood, and personality changes. That remains the biggest challenge for families. And when brain injury survivors rate themselves, they actually rate their physical problems as being most burdensome. And they actually agree least about emotional behavioral problems because likely they may not have the insight into how their personal, emotional, and behavioral problems or their own personality has shifted. So they tend to have less insight. And because of that, brain injury survivors rate physical symptoms as being more problematic, and the emotion being less problematic, which is the reverse of families. And that's frustrating too, right? Because there's like a mismatch. Families are worried about the behavior and the emotions. The brain injury survivors more worried about the physical. Over time, family burdens can increase. And why does that happen? Well, often the signs and symptoms of a brain injury, particularly emotional, behavioral, and personality, can worsen. People get more depressed. Brain injury survivors get more depressed. There's more use of substances. There's that mobile mourning where the individual isn't meeting the milestones that they were supposed to meet, going to college or being able to move out of one's parents' home, for example. So we see family burdens really increase, and that's less about the severity of the brain injury, and again, more about the personality changes and this mobile mourning. So the severity of the brain injury doesn't always match the degree of burden families feel. Every family is really different, and that's really important. And a good assessment, which we're going to talk about, is really helpful. So just because someone had a severe brain injury, and I've worked with families that are taking care of profoundly injured clients that have had brain injuries, but they have very few of the caregiver burdens. And I have family members that are struggling significantly because while their family member is able to even return to work, their personality has changed so much, right? So the degree of deficits does not correspond to the degree of burden. Here's a caregiver burden scale, just to look at what are some of the ways that the burden can show up for family members. There's a general strain, right? You can see some of the questions, feeling tired or worn down or psychologically stressed. The isolation that family members feel, they don't want to invite people over, right? The disappointment when they feel like life, I was supposed to retire and now I'm caring for, my child, or I married the love of my life and now my wife is no longer that person. The economic sacrifice, because maybe the caregiver can't work the amount of hours, or the person that was injured was the breadwinner. Emotionally, are you feeling embarrassed about your relative's behavior, right? And then the environment, maybe you having people in your house all the time, which could be really stressful, right? Or that your environment makes it hard. It's not really handicapped accessible. And so it's hard to shower your loved one. So these are different ways to think about burden. So typically the caregivers tend to be more female, and that's why this study talks about mothers and wives. Of course, we also have husbands and fathers and brothers that take care of their loved ones too. But we see that the reported symptoms really, really pretty high across the board, particularly the highest for the spouse, right? And that very well may be related to that mobile mourning idea of losing their partner, right? Losing their partner and no longer having that equal relationship. Now the wife becomes the parent in a lot of ways. And that it can be a very challenging caregiver dynamic, right? A spouse caring for their loved one can become more of a parental role. So what are the personality changes that specifically impact family members? So number one is this impaired social perceptiveness, ignoring social cues or misreading social situations. And again, this goes back to losing the sense of the person that was there before, right? Someone who is overly concrete, not able to reason, gets really stuck on things, can't plan, because all of that then shifts over to a different family member, right? If someone who was always the planner of the family can't plan anymore, then that burden is taken over, or that role and responsibility is taken over. Number 3 and 4 tend to be the most painful, which is this emotional dysregulation, outbursts, saying things inappropriately, emotional alterations, mood swings, outbursts. Imagine how painful that is, because it's unpredictable and because it's often a departure from how the person was before the injury. And finally, inability to learn from new experiences. So memory issues, concrete reasoning, the person doesn't learn. So the caregiver's responsibility is to go over the same information over and over again, and how draining that can be for family members. So the pre-injury family also plays a role in the post-injury reaction. So there's been research over the years looking at if a family was already at risk prior to a family member sustaining a brain injury, they are considered a vulnerable family, right? And these vulnerable families often have extreme adjustment following a traumatic brain injury. And that doesn't mean that the person's injury is more severe. It actually could be less severe, but they were already vulnerable. So what do I mean by vulnerable? Maybe the family had financial hardship, so that when someone was injured, that put them into extreme financial distress, right? Maybe they become unhoused as a result of the lack of money coming into the system, right? So that could be a financial stress. It could be emotional. It could already be that the relationships were not good before. Communication was impaired. Maybe there was someone using substances before the injury. It doesn't even necessarily have to be the person that had the injury, but imagining someone uses substances before the injury and now they have to be the caregiver and they're using substances, so they can't actually take care of their family member. So the more distress a family has and the more unhealthy or maladaptive coping they had prior to the injury, and if some of those dynamics were severe, we can imagine that the burden of a brain injury can really be significant. So let's talk a little bit about these reactions. And this isn't just vulnerable families, but particularly when there's a vulnerable family before we often see this magnified or exacerbated. So like I showed earlier, that slide, that spouses tend to have the biggest challenge, particularly females that tend to be the caregivers. Again, not always. The loss of a partner is so profound. And I've heard this many, many times in working with husbands and wives. This isn't the person I married, right? And what do you do in that situation? And depending on a person's belief system, religion, family, of origin, reactions, they may feel very trapped, right? They may say, I don't want a divorce. I can't, it's death until death do us part. On the other hand, I don't want to be with this person anymore. They're not the same person. Financial hardships, social limbo. Am I married still? This person is in a wheelchair. They're completely disabled. Is this a marriage, right? And so what do we talk about with intimacy? If I'm not intimate with my partner, what do I do, right? So these are things that often spouses don't even share. It's like private, right? But they are internally struggling with their own unmet needs, right? Caregiver burdens are a combination, remember that slide earlier, between their own unmet needs and their individual they're caring for, their behavioral, emotional, and cognitive changes, right? So you can see how a spouse can feel increasingly squeezed. Their own unmet needs plus their partner's needs. So when we predict how a spouse is going to adjust to a brain injury, we're looking at the severity of the injury, physical restrictions, psychological adjustment of the injury with the patients, that's the individual that they're caring for, how the family is functioning, and then the personality of the spouse and how effective or ineffective the spouse's coping skills are. And then also the history of how the spouses got along. A marriage that was very strong before the brain injury tends to do better than a marriage that was already fractured before the injury. Intimacy in the marital relationship matters because once the intimacy is affected, it is much harder for spouses to be able to feel like they have a partnership. And we also know that their needs are not getting met on an intimate level. So those are predictors. These are all ways to predict how well is somebody going to adjust when they have to care for their spouses. And we see high levels of spousal stress and divorce. Family member reactions, I'm going to go through some other groups now. So we talked about spouses. Parents often resume the role of caregivers. And that can be really challenging, particularly when they have been emerged adults now returning as a childlike dependent, right? And so when brain injuries happen, and they often happen when young people are somewhere between 18 to 24, right? So sort of in their prime, and they're emerging, going to college or just graduated, and then suddenly they have a brain injury as a result of a motor vehicle accident, for example. They come home and the parents have to resume their role as caring, and not just a 24-year-old, but now they have needs and transportation and physical issues that may require a parent to even do very personal care. How difficult that is. I see in working with lots of parents a lot of guilt and self-blame. If only I had caught my son's drinking problem earlier, if I hadn't let him drive that night, if I had sent him to a therapist, earlier so he wouldn't have had a suicide attempt, right? So a lot of blaming, and parents tend to have guilt, already for any challenge that a child might bring, never mind a catastrophic accident. When we see families really struggling, it's often because they're not taking care of their own responsibilities. They have changed and uprooted their life. Maybe they had to quit their jobs, or they stopped caring for the pets and other children in the home. And we also see, and I've seen this dynamic a lot, old problems reemerge. So let's say, for example, someone has gone to college and has moved out, has a brain injury, has to move back in with mom and dad. And when she does, some of those same dynamics that happened when Julie was 15 are now reemerging. The same arguments, the same fights. And Julie doesn't have as much control, impulse control as her parents. So she may get really frustrated and start throwing things, hitting her parents, right? And can you imagine how stressful that could be for the whole family system? So old problems are more likely to reemerge when a family system is stressed. So parent-child dynamics often come back, even when they were sort of worked through at an earlier time. Siblings. So siblings can have a really hard time when a sibling is injured, particularly when they're younger, 18 and under, because they often have a different role in the family. They may have to become caretaker for their sibling, or they get less attention. I've seen this in many family systems where the sibling ends up being sort of on the sidelines. They're the normal one. They don't have to be worried about. And as a result, they either become overly parentified or they get really rebellious. They start using substances. They develop their own set of problem behaviors to get their needs met, because of course all children need attention, love, and kindness. So it can be very difficult for siblings. And again, they can feel guilty. Like, how can I complain when my brother now is paralyzed, right? So it's like a very difficult role. And they also sometimes have to parent their parents because their parents are in such distress. So siblings are sometimes an underlooked at group that can need a lot of emotional and psychological help at times. Children. So if someone has children and the parent is injured, the child can be, particularly when they're young, can be very scared of the parent. If the parent's having reactions, yelling, screaming, or needs, to have their undergarment changed, for a child, that could be so upsetting. And we can see that we'll see these children sometimes have trouble in school, separation anxiety, or not wanting to have people over, feel embarrassed, become increasingly isolated. So the perspective of each family member is really important when we're working with the whole system. We don't want to neglect the different roles and responsibilities that each family member has, and really checking in with how the family is doing. And then we have extended family. Extended family can be very helpful. They also, of course, feel the pain, grandparents, aunts, uncles, cousins, but they also can be really helpful for additional support. They can come in and provide respite. They can, spend time with the siblings, so they can have a really important they can parent their grown parent who's parenting their injured child. So it can really be an extension and a lifeline. All right, so let's talk about how do we help families cope. So number one, we have to evaluate the needs of the family. We want to look at how do we, first of all, intervene by assessing each family member in the family system, and then provide interventions that match where the family needs it the most, right? Every family is different. So when we want to create our intervention, we want to make sure that it matches this unique family constellation. So this slide talks about assessment sort of in a multifaceted way. So first of all, we're looking at the individual, the family, individual family members, the family as a system, and then the relationship of the family to the community. So individual family members, spouse, parent, sibling, etc., the family as a unit, and then how they interact with the community. And then we want to look at different ways to intervene: evaluation in the beginning, then moving toward information and education, then towards support, restructuring, problem solving, and then maybe toward formal therapy. So these levels start with evaluation and then move toward formal therapy. And depending on where the person and the family are in their stages of intervention, we may be doing different things at different times. So for example, in acute care, we're not going to talk about how to manage vocational assessments and getting the person back to work. That would be more community reintegration. So we want to match the stage of intervention with the appropriate level and the appropriate circle, right? So we want to consider, who are we providing the intervention for? What is the level, and what stage is the family and individual at? All right, so I'll give you some examples. So first, if we're looking at the individual, we're looking at both the individual with the injury and individual family members. So sometimes we're looking at the individual, their own strengths and weaknesses, so we can see what the family has to work with. And then we're looking at the expectations of the people living with a brain injury client. We're looking at coping skills, and we're looking at risk factors. And this is both for the individual with the brain injury and family members, right? So each individual gets an evaluation, ideally. The family members don't necessarily need a neuropsychological evaluation, but much more around their own coping skills and emotional functioning. We also want to look at the family system, that second circle. How is the family system functioning now? What are the roles? How cohesive is the family? How flexible is the family to navigate these changes? What are the cultural norms? Who's the breadwinner? Who's the caretaker? And how did that shift? And what are the family's expectations? So we go from individual to family. And then how does the family interact with the community? And this potentially could be supports that we're going to tap into. So rehabilitative services, schools, recreation, religious groups, extended families, and caregivers. So how does the family system interact and access these supports? So we want to think about all of these different dynamics and first just assess, what do we have? How connected is the family to these different institutions? So at the very first stage, we want to think about providing information. And this could happen in the acute phase, and it can happen ongoing as the person's needs change. So essentially, we could talk about brain injury associations, the Department of Social Services, if the person's eligible for something like the Acquired Brain Injury Waiver Program, and caregiver basics. How do you hire a caregiver? Does my insurance cover this? What services can I get? How long can I get the services? So that's that very first stage, which could happen in any acute rehabilitation or community stage of recovery. The second of the three levels is support, problem solving, and restructuring. So this is when it's more specific, when the needs are more clear for what the individual is going to need and what the caregiver and the family are going to need. And this is where we begin to think about what kind of ongoing supports the family system may need. Caregivers are going to need ongoing support. And we know as the individual's distress levels go up, and their patient satisfaction goes down, their life satisfaction goes down, the caregiver is impacted. So as well as the individual does, that often mirrors how well the caregiver is. Not always, but often. So we want to think about helping the family with simple things like problem solving. How do we work as a family during these crisis times, right? Especially in the early stages, we're talking about 3, 6, 9 months after the injury. So first of all, looking at what are the responsibilities now? If there's a sibling that is having to take over walking the dog, for example, right? We want the family also to have ongoing ways to take time out, refresh, provide relaxation techniques. I'm going to be talking about this in another webinar about some specific relaxation and grounding exercises when families are stressed. Communication, really hearing each other out, being honest and having difficult but honest conversations. Sometimes paying for help can be a huge, weight off of the family system. And so talking about that, what kind of help can we get? A brain injury support group or consulting a counselor, which I'm going to talk about a little bit further. Making time for oneself is critical for family members. And asking for that extended family member support. And then spelling each other, taking breaks. That is really, really helpful. So these are some more, I want to call them like practical, pragmatic problem solving techniques that we can use once the new equilibrium is beginning to formulate. And then finally, restructuring. And so I'm going to talk about it in the context of developing a home services plan, like the ABI waiver, as an example of how a family may have to restructure their environment. And that may include financial changes, like getting a special needs trust, getting on Social Security disability, and home modifications as well. So the Acquired Brain Injury Waiver Program, which I talk about in another webinar more extensively, is a home-based program to help people that have had a brain injury live in the community. And it's really designed to help people learn to improve or retain skills to live successfully. It's a person-focused, person-centered program. And often it includes living in home with other people, most likely family, sometimes individually, but many programs, including the ABI waiver program, focus on providing services to an individual that live in a family. So we want to incorporate families into this process. So when we think about developing a home-based program in someone's home, we want to include the people that are in the home. So as we start to plan it, it's really important right off the bat to have families at the table. Families are really vital in terms of hiring staff. Who do you want to be in your home? Having meetings and feeling like they're part of the meeting and listened to. Some kind of daily communication with providers is really helpful for family members. And ongoing education and training, the families need this on an ongoing basis because the individual they're living with and providing care to is changing as well over time. I'd like to review a case now and then share a few more slides based on the case. Again, these are cases I've been sharing in different webinars that are composites of many clients I've worked with. So Kelly is a 24-year-old single mom. Her son is 5 years old, and she was living independently prior to her injury. She sustained a severe traumatic brain injury as a result of being a passenger in a vehicle that was on a high-speed drive. There was drunk driving involved with the other driver in the other car. And she developed significant physical and cognitive and emotional limitations. And one of the biggest challenges with Kelly and her plan in the community was that she's got a son and she can't really care for him. She loves her son, she is devoted to him, and she physically and emotionally and cognitively doesn't have the capacity to fully parent him. So her parents had to take over the role of caring both for Kelly and for her son. And so that dynamic, you can see right off the bat, is really challenging. And as providers came in and began to work with Kelly, they found many challenges. So I'm going to talk a little bit about that now. So when we're providing services to people like Kelly and her parents and her son, we have to be really clear, what are the boundaries, right? And so who are we caring for, right? And so we want to make sure that children are included in the treatment because they are vital. In Kelly's case, her son was the reason why she did things. She said, I'm doing this for my son. I want to be a good parent. So that was very motivating. And she also did not have good insight into her ability to parent. So she would often be a very lax caregiver, or she would vacillate and be very strict. She could even be physically aggressive, potentially sometimes. So it was very difficult for the people working with Kelly to help her because they weren't there to care for her son. They were there to care for Kelly. So you can see right off the bat how challenging it is. We want children to be part of the plan because they are vital. And at the same time, caregivers are there for Kelly. And in the situation, we have to be really clear who is doing what. And when I work with families that have young children involved, we really want to be clear of who can do what. So no one is going to be walking the son to school if they're supposed to be caring for Kelly. If Kelly wants to walk her son to school, the caregiver can go with her, right? So these are different ways to establish treatment goals that are appropriate and stay within the boundaries of the family. We also deal with families that are unrealistic. So in Kelly's case, her family felt, her parents were hopeful that she would be eventually able to move back out and take care of her son. And it was clear, given the extent of her deficits, that that was probably not going to happen. And so, but we don't go in, whether you're a caregiver, a therapist, a nurse, and say, that's not going to happen, family, because that could be devastating, particularly if the family is not ready to hear that, if they're not at a stage of grieving where they can accept and take in that information. So we treat the hopes and dreams with respect, and we just continue providing education and good boundaries and keeping in mind the goals for right now. So instead of focusing on Kelly moving out and taking care of her son, we focus on how can Kelly help her son with his bedtime routine. That's still really important. And in fact, it's a precursor to taking on more parenting roles without it being dangerous, risky, or inappropriate. We talk about sometimes just this open mind. We don't know what the future holds, although the prognosis for someone like Kelly, who's got a lot of impairments, may not look good on paper. Sometimes people change anyway. And so we want to be optimistic, realistic, and goal-oriented in the here and now. And it's good to have contingency plans. So we had contingency plans in Kelly's situation. If she was too tired to put her son to bed, we would say, okay, your mom's gonna do his story time tonight. And we kept a very generous, open-minded attitude so that she didn't feel discouraged or shamed, right? So these are some of the ways to work with families. And I like the here and now as the main way to help when families tend to have very, very, maybe overly optimistic or potentially unrealistic ideas. Some families are overprotective. We saw this also in Kelly's situation, where families may come in and micromanage. They want to go to every session. They don't trust her to go out with her caregiver in the community. So they want to be part of every single aspect of the care. And the family member, let's say in Kelly's case, gets angry and doesn't want her family involved. So we want to work with families so that we're embracing that they love and protect their loved one, their family member, but also we want to help them to gradually trust the team approach. So I love this idea of good communication. I often work with teams on this idea of establishing daily communication so that families are confident that what is happening is supposed to happen, that their loved one is getting their needs met so they can back off. And that's really the goal. So families don't get so burned out that they can have providers, they can have vocational coaches, they can have extended family come in, as long as they know what's happening. So whether it's daily communication and then monthly evaluation of goals, we want to really work on good communication and ongoing goal setting. When that information is relayed to families, they can feel more at ease. I also like to set goals that are going to succeed. So when family members are overprotective or have really high expectations, we want to set the goals to be, realistic so that they feel success and there's momentum to build on. So in Kelly's case, let's say the goal was to put her son to bed and to read a book to him every night. So maybe we would scale back that goal and say that she would start to read a book 3 times a week for 5 minutes and then have another family member come in and finish the book because she'd get too tired. So we start really gradual so that by the time she gets to the goal of finishing the book, she feels fantastic. Her child loves it because he's getting all of mom's attention, and the family feels like, she's meeting the goals, right? So let's start with small goals that have a high probability of success and then move toward more complex goals over time. So sometimes families have a lot of challenges. Now, in Kelly's case, the family really started to struggle over time. The demands as her son got older, and this was 5 or 6 years post-injury, he became, a prepubescent adolescent, almost adolescent, and it was really stressful. There was lots of aggression back and forth. There was some potential concerns around abuse, although it wasn't founded. But we needed to get more supports for this family. The family became right at the level of crisis. And so when we're working with families at this level, it's really important to get mental health professionals in to talk about whether we need to get Department of Children and Families or other community organizations involved. Do we need to look at other options because it's just too difficult for the family right now? And I like to think about, and I often tell this to families because they feel very, very distressed when even a discussion of an alternate placement is explored, to think about all options should be on the table at any point in time. It doesn't mean anyone's failed. It means that at this point in time, this isn't working, right? So we want to take away the stigma and the shame and really focus on how can we support the family now, because it can change over time, right? So maybe this family needs to have time where Kelly is on her own, or Kelly has her own plan and her son stays with the grandparents. There are many different ways that families can provide care and also change up what isn't working. We know families, particularly families that are marginalized, have a harder time because there may be difficulty accessing services, or providers don't speak the same language, or there may be misunderstandings around how cultures deal with things like injury or illness. Some cultures have a lot of stigma about mental health and won't report if a loved one is suicidal, because that is seen as something that is a prohibition according to the religion. So we don't want to assume that a family has a view until we check with the family and really ask them about their views, right? So we want to always do that assessment, and we can go back and do that again and again. Family members, individuals, the community, that's where we're continuously assessing and getting information so we can address the challenges that they may be facing. So when a family system becomes dysfunctional or the stress level becomes unmanageable, we want to get professional help. And I like to think about this, and I say this to families often, that if someone was sick, or if your care, the person you're providing care to was sick, you'd call the doctor, right? When a family becomes unwell, families are hesitant sometimes to reach out, and it's very simple. We can reach out, it's not always easy, but it is simple that when the family's ill, we need to reach out for the proper treater. And in this case, it may be an individual and or family therapist. We want people talking, communicating, and sharing what's happening. That's the beginning of the healing, when people can actually verbalize what's happening and then get strategies. So therapy helps to, first of all, get support, bring compassion in, be able to hear everyone's perspective and story, and then get specific coping skills so that they can effectively manage the situation. So this is an overview of a very complex topic around how families cope with acquired brain injury survivors. And for additional coping skills and ways to prevent caregiver burnout, please look for an additional webinar I'll be offering on this topic. Thank you so much.